Welcome back to the deep dive. We're diving into something really specific today, and this actually comes straight from a listener request.
That's right.
So this deep dive is tailored just for you, especially if you're maybe hitting the books, revision mode, and need to get a solid handle on a tricky medical topic.
Yep, we've got a set of sources here. Looks like articles, research notes, basically high-yield revision stuff, all focusing on one condition: oligohydramnios.
Oligohydramnios. Okay, sounds a bit complex and probably pretty significant.
It can be, yeah.
So our mission today is basically to crack open these notes, pull out only the absolutely crucial need-to-know info. We're kind of building you a streamlined, high-impact study guide right here.
Exactly. No extra fluff, just the core definitions, those key numbers you need to remember, the mechanisms, what it actually looks like clinically, how it's managed, and, why it matters.
And we're focusing strictly on oligohydramnios.
Strictly. Laser focus for revision.
Okay, perfect. So settle in. We're going to try and make this stick. This is your shortcut, hopefully, to being confidently informed about oligohydramnios. Let's dig in.
Okay, so let's start with the absolute basics. What is oligohydramnios? According to these sources, it's defined pretty clearly as a condition where there's an abnormally low amount of amniotic fluid, the fluid surrounding the baby during pregnancy.
Right, low fluid. Simple
Yeah.
enough, but why is that such a big deal?
Well, it's significant because low amniotic fluid, it's strongly associated with poorer outcomes, things like intrauterine growth restriction, that's IUGR.
Where the baby isn't growing well.
Exactly. And unfortunately, it's also linked to a higher risk of perinatal mortality. So it's definitely not just, a minor variation we can ignore.
Okay, serious implications then. So
Yeah.
how do we actually quantify low? Are there specific thresholds, like numbers we need to remember for diagnosis? Because the sources seem to list some key figures here.
Yes, and these numbers are absolutely crucial for diagnosis, especially for recall, like you said. The notes give us a few ways to diagnose it.
Okay.
One is based on the total estimated volume. If it's less than 500 milliliters of amniotic fluid, specifically between 32 and 36 weeks gestation.
500 milliliters, 32, 36 weeks. Got it.
Another way uses ultrasound measurements, usually done in the late mid-trimester. You can measure the maximum vertical pocket, or MVP. That's the deepest single pocket of fluid you can find that's unobstructed.
MVP, right.
If that MVP measures less than 2 centimeters, that's one diagnostic criterion.
Less than 2 centimeters. Okay.
The other really common method is the amniotic fluid index, or AFI. For this, you imagine dividing the uterus into 4 quadrants and measure the deepest pocket in each one, then add them up.
Summing the 4 quadrants.
Yeah. And an AFI of less than 5 centimeters is diagnostic. Sometimes it's defined as below the 5th percentile for that specific gestational age, again, usually measured in the late mid-trimester.
Okay, so let's recap those numbers because they feel important. MVP less than 2 centimeters, AFI less than 5 centimeters or below the 5th percentile, both typically late mid-trimester. Or, later on, less than 500 milliliter total volume around 32, 36 weeks.
Exactly. Those are the critical thresholds highlighted in these notes. And just for a bit of background, the sources touch on the physiology of amniotic fluid.
How it normally works.
Yeah. The volume generally increases through pregnancy, usually peaking around 34 to 36 weeks, typically at about a liter.
A full liter. Wow.
And the fluid mainly comes from fetal urine, the baby's pee, and also fetal respiratory secretions. It's cleared primarily by the fetus swallowing it.
So fetal urine and breathing fluid out are the main producers, and swallowing takes it away. That kind of makes sense. And I think the notes mentioned maternal hydration plays a role too.
Yeah, it does. Yeah, the notes point that out.
Yeah.
And that becomes relevant when we talk about management later. Increasing mom's fluid intake can actually influence the amniotic fluid volume.
Interesting how those factors balance out. So, okay, how common is this? What do the numbers say about prevalence? Are we seeing this a lot?
Well, looking at the UK data referenced in the sources, the estimated incidence overall for oligohydramnios is somewhere between 1% and 5% of pregnancies.
5%.
Severe oligohydramnios, though, is less common, maybe around 0.7%. But what's really striking, and the notes emphasize this, is how much more common it gets post-term.
After the due date.
Yeah, beyond 41 weeks. In those pregnancies, it can affect up to 12%.
Wow, 12% after 41 weeks. That's a pretty big jump from the baseline, 15%. Really highlights why, keeping a closer eye on post-term pregnancies is so important.
Definitely. And knowing those numbers gives you a good sense of the context, how often you might actually encounter this condition.
Okay, so let's get into the why. What actually causes oligohydramnios and who's most at risk? The sources seem to break this down into a few categories.
Yeah, and thinking about the causes and the risk factors together is often helpful because there's quite a bit of overlap. We can use the sources breakdown almost like a checklist when you're thinking through possibilities.
A checklist approach, I like that.
So first up, fetal factors. These are issues with the baby itself. Big ones here are chromosomal or congenital abnormalities, especially problems with the kidneys or urinary tract.
Because fetal urine is key for fluid production, right?
Exactly. So if the kidneys haven't formed properly, or they're not working, or there's a blockage, like obstructive uropathy, fluid production just plummets. Other fetal factors include intrauterine growth restriction, IUGR itself, being post-term, premature rupture of membranes, PROM,
Water's breaking early.
yeah, causing fluid loss, and sadly, fetal demise is also a cause.
Okay, so fetal factors. What's next?
Next is placental factors, so issues with the placenta. These can reduce blood flow and nutrient supply to the fetus, which then impacts fluid production. Examples are placental abruption, where the placenta detaches too early, or in twin pregnancies, twin-to-twin transfusion syndrome.
Right, placental problems affecting the supply line.
Then you have maternal factors, conditions affecting the mother. Simple one is dehydration, less fluid in, potentially less fluid available. Then there's uteroplacental insufficiency, meaning the placenta just isn't working optimally to get blood to the uterus and baby.
Which could be linked to other conditions.
Yes, like high blood pressure conditions, chronic hypertension or preeclampsia, also diabetes, or chronic hypoxia. They can all affect placental function and blood flow.
Okay, any others?
There are drug-induced causes. Specific medications the mother might be taking can interfere with fetal kidney function or blood flow. The notes specifically call out indomedacin, which is an NSAID, and ACE inhibitors, often used for blood pressure.
Indomedacin and ACE inhibitors, good ones to remember.
And finally, sometimes it's just idiopathic, meaning despite looking, we don't find a clear cause.
That structured approach, fetal, placental, maternal, drug, idiopathic, feels like a really useful way to organize the potential causes in your head. And the specific risk factors the notes list seem to map right onto these categories. Maternal dehydration, preeclampsia, chronic hypertension, diabetes, IUGR, multiple pregnancies, fetal kidney urinary tract abnormalities. Makes sense.
Absolutely. Running through that mental checklist can be super helpful, either in a clinical situation or just for revision recall.
Okay, so that covers the what and the why. Let's move to the how, the pathophysiology. How does this low fluid state actually happen? And physically, how does it impact the fetus?
So fundamentally, oligohydramnios comes down to an imbalance. Either the fetus isn't producing enough amniotic fluid, or it's losing fluid faster than it's being made. Simple as that, production versus loss.
Okay, production down or loss up?
Yeah. And thinking about how this affects the fetus, it's really important to remember that amniotic fluid isn't just empty space. It acts like a protective cushion, right? And it's a vital environment for development. Without enough fluid, that cushioning effect is lost.
Ah, so the lack of space in that protective buffer is the key issue.
Precisely. The consequences for the fetus really stem from that. Fluid is needed for things like normal lung development. The fetus actually practices breathing by moving fluid in and out of its lungs.
Right, I remember reading that.
And it also gives the fetus room to move, which is essential for developing its musculoskeletal structure properly without being all cramped and constricted. So low fluid can really disrupt fetal development. It can lead to organ compression, problems with the umbilical cord because it's not floating freely and can get squashed.
Cutting off supply?
Potentially, yes.
Yeah.
And it can also worsen growth restriction. The associated conditions mentioned in the sources, like ruptured membranes causing fluid loss, or fetal urinary tract malformations reducing production, or reduced urine output because of poor blood flow to the kidneys, they all fit into that production or loss imbalance idea.
Understanding that helps explain why we see the clinical features and complications we do.
Exactly. It connects the dots.
Okay, that cushion and space analogy really helps visualize the impact. So what does this actually look like clinically? What signs might make you suspect oligohydramnios?
Well, the notes point out that if it's mild, it might actually be asymptomatic. You might not see any obvious symptoms at all.
Could be an incidental finding on a scan.
Often is. But in more severe cases, you might get the mother reporting decreased fetal movement. That's a common one. On examination, or more likely on ultrasound, you might see poor fetal growth, the baby measuring small for dates.
Okay.
And during fetal monitoring, like with a CTG, you might see abnormal fetal heart rate patterns. These can be a red flag suggesting maybe the umbilical cord is being compressed or The baby just isn't coping well in that restricted environment?
So signs the baby's not happy or is being physically restricted. Decreased kicks, slow growth, worrying heart rate patterns, those are the key things to look out for, particularly in severe cases.
Definitely.
And if you were thinking about a test question, it might be something like, a patient at, say, 35 weeks reports significantly fewer baby movements. Fundal height is lagging, and monitoring shows some late decelerations. Which condition should be high on your list? Oligohydramnios would be a really strong possibility there.
Exactly. Those are classic pointers that should trigger further investigation.
And speaking of investigation, how do we actually pin down the diagnosis? What tests are involved?
Ultrasound is number one. It's the primary method, absolutely. It's how we actually see and measure the fluid levels and also assess the overall fetal well-being at the same time.
And you said it's often picked up instantly.
Yeah, during a routine scan or maybe during surveillance scans if the pregnancy is already considered high risk for other reasons. And the notes specify those two main measurement methods we talked about earlier, the maximum vertical pocket depth, the MVP, or the amniotic fluid index, the AFI.
Right, MVP and AFI via ultrasound.
Yep.
So ultrasound first for measurement. What about checking how the baby's actually doing overall?
If there are concerns based on the ultrasound measurements or the clinical picture, then a fetal biophysical profile, or BPP, is often done. This is basically an ultrasound-based test that looks at several things: fetal movement, breathing movements, muscle tone, and the fluid level itself to generate a score reflecting fetal well-being.
Like a health check score for the baby.
Pretty much. And if placental insufficiency is suspected as the underlying cause, then Doppler ultrasound is really useful. This specifically looks at blood flow patterns in the umbilical cord and other fetal blood vessels.
Giving clues about placental function.
Exactly. It tells you a lot about how well the placenta is delivering oxygen and nutrients.
Okay. And given that ruptured membranes, PROM, is a major cause, checking for that must be important too.
Absolutely critical. If PROM is suspected, maybe the mother reports leaking fluid, then a sterile speculum examination is needed.
To actually look.
Yes, and often using something like nitrazine paper or sticks. These change color usually yellow to blue if they come into contact with alkaline amniotic fluid, which helps confirm if the membranes have ruptured.
Okay, so the investigation pathway seems logical. You start with imaging ultrasound to measure the fluid, then maybe functional tests, BPP, Doppler if you're worried about the baby or placenta, and then specific tests, speculum exam, nitrazine, maybe even amniocentesis in some cases, to hunt for the underlying cause like ROM or specific fetal issues.
That's a great way to think about the sequence, yeah. Imaging, function, cause.
Makes sense. Now, what about things that could look like oligohydramnios but aren't quite the same, the differential diagnoses?
Yeah, the notes list a few important ones to keep in mind. Sometimes amniotic fluid levels just have normal physiological variations. They might be on the lower side of average, but still within a range that isn't actually causing problems.
So just naturally lower, but okay.
Exactly. Then there's premature rupture of membranes, PROM. This is a bit tricky because, as we said, it's a major cause of oligohydramnios, but it's also in the differential. When you find low fluid, you have to ask, is the low fluid the primary issue, or is it because the membranes have ruptured?
Right, cause versus consequence.
Similarly, placental insufficiency and fetal abnormalities are key causes, but you need to figure out if the low fluid is an isolated finding or if it's actually a symptom or consequence of one of these other underlying conditions.
So the differential isn't just what else could this be, it's also about figuring out if the low fluid is the root problem or just a sign pointing to something else like placental failure or a fetal anomaly. Really emphasizes why that thorough investigation is so crucial.
Precisely. You need to identify the underlying reason to manage it properly.
Okay, speaking of management, once we've diagnosed oligohydramnios, maybe found a cause, maybe not, what's the plan? What do we actually do about it?
Well, management is really highly dependent on a few things: the severity of the oligohydramnios, the underlying cause if one's identified, and critically, the gestational age, how far along the pregnancy is.
Okay.
The notes suggest starting with conservative measures in some cases, things like increasing maternal hydration and just keeping a very close eye on things through monitoring.
And wasn't there a specific point about hydration in the notes?
Yes, they actually note that treating maternal dehydration can potentially increase the amniotic fluid volume by up to 30%. It's a relatively simple thing to try, and it might make a difference, particularly in milder cases or where dehydration is suspected.
30% boost? That's potentially significant. But what about more severe cases?
In severe cases, or if there are other concerning signs, management often shifts towards much more intensive monitoring of fetal well-being, and sometimes it leads towards planning for delivery.
And gestational age is the big decider there.
It plays a huge role. The notes break down the management based on timing.
If oligohydramnios is found before the baby is term, the approach is often expectant management. Basically, watchful waiting, but with very close surveillance.
What does that involve?
Regular checks on fetal growth, keeping track of the amniotic fluid volume itself over time, and continuous fetal heart rate monitoring if the mother goes into labor. The goal is usually to try and safely prolong the pregnancy if possible, assuming both mother and baby are stable.
Okay, buy some time safely. What about at term?
At term. So 37 weeks or more. Delivery is often considered the appropriate course of action, especially if there are any signs of fetal compromise, or if the oligohydramnios is quite severe. However, the notes do say that delaying delivery is possible if all the fetal testing looks reassuring.
So delivery is likely, but not automatic if the baby seems okay.
Right. And then after term. This is that post-term group, beyond 41 weeks, where we know oligohydramnios is more common. Interestingly, the notes state that isolated oligohydramnios in post-term patients, meaning low fluid but no other worrying features, doesn't necessarily increase the risk of needing a C-section.
Oh, that's interesting.
And importantly, they state there's insufficient evidence cited to support inducing labor just because of isolated oligohydramnios in these post-term patients.
That's a really key point for revision. Isolated oligo post-term doesn't automatically mean induction, according to these notes. What about more direct interventions to increase the fluid?
The sources mention two specific interventions for certain situations. One is amnioinfusion. This involves infusing fluid, usually sterile saline, directly into the amniotic sac through the uterine wall, guided by ultrasound.
Why would you do that?
It's typically done to temporarily boost the fluid volume, sometimes during labor, maybe to try and cushion the umbilical cord and prevent compression. The notes do highlight, though, that this procedure requires special arrangements with audit and research.
Meaning it's not routine.
Exactly. It suggests it's a more specialized procedure, not something done casually. The other intervention mentioned is vesico-amniotic shunts.
Hunts.
Yes, this is a fetal therapy procedure done in utero, specifically when oligohydramnios is caused by a fetal obstructive uropathy, a blockage in the baby's urinary system. A tiny shunt is placed to bypass the blockage, allowing urine to drain out into the amniotic sac again.
To restore fluid production.
Precisely. And while this can effectively reverse the oligohydramnios, the notes caution that its success in achieving good, sustainable long-term kidney function for the baby is variable. And this too falls under that special arrangements with audit and research category.
Okay, so amnioinfusion for temporary volume boost, shunts for specific fetal urinary blockages, both quite specialized interventions. It really shows that the management approach is a careful balancing act based on the cause, the severity, and crucially, how far along the pregnancy is.
Absolutely. It requires a really nuanced understanding of the whole clinical picture.
All right, let's shift to outcomes. What's the typical prognosis? What's the likely outcome when oligohydramnios is diagnosed?
Well, the prognosis varies quite significantly. Again, it really depends heavily on the underlying cause and maybe most importantly, the gestational age when it's first picked up.
Timing matters again.
Hugely. The notes make a really crucial distinction here. Oligohydramnios diagnosed in the second trimester is much more strongly associated with underlying fetal anomalies.
So finding it early, like before 24 weeks, is often a red flag for a more fundamental problem with the baby's development.
That's the key implication, yes. In contrast, oligohydramnios diagnosed later in the third trimester is more often of unexplained origin or perhaps linked to less severe causes like being post-term or maybe temporary maternal factors like dehydration.
Okay, that makes sense.
Severe cases, though, regardless of when they occur, generally carry a higher risk of fetal morbidity. That means illness or significant health problems for the baby after birth. Even isolated oligohydramnios, meaning low fluid without other obvious issues, is linked to specific risks like meconium aspiration.
Baby inhaling meconium during birth?
Yes, also an increased likelihood of needing a cesarean delivery and a higher chance the baby will need admission to the neonatal intensive care unit, the NICU. And if oligohydramnios is diagnosed alongside other problems, other comorbidities, that significantly bumps up the risk of the baby having a low birth weight.
So the timing of diagnosis really gives a major clue about the potential underlying issue and therefore the likely outcome. That really underlines why getting the diagnosis right and understanding the full context is so critical.
It provides that framework for anticipating potential challenges and counseling patients appropriately.
And finally, let's talk about those challenges, the potential complications. What specifically can go wrong for the fetus because of the low fluid or because of the conditions causing it?
The lack of amniotic fluid or the underlying issues driving it can lead to several pretty serious complications listed in these sources. A major one is something called Potter sequence or Potter syndrome. It's not really a single syndrome, but more a constellation of physical abnormalities that happen because the baby hasn't had enough space or fluid to develop properly inside the womb.
Due to the compression.
Exactly. This often includes pulmonary hypoplasia, which means critically underdeveloped lungs. This happens because, as we mentioned, the baby needs to practice breathing that amniotic fluid for the lungs to mature properly.
Underdeveloped lungs just because there wasn't enough fluid to breathe? That's a really stark consequence.
It really is, and one of the most serious.
Yeah.
The lack of fluid also causes fetal compression syndrome more broadly. The baby's body or organs get compressed, which can lead to deformities or problems with development, like limb contractures.
Okay.
If the low fluid is associated with a chronic leak or rupture of the membranes, there's also an increased risk of infection ascending from the vagina up into the uterus and reaching the baby.
Makes sense. Loss of the protective barrier.
Yeah, and in some situations, particularly with membrane rupture, or if fibrous bands form within the amniotic sac, there's a risk of amniotic band syndrome. This is where these tight bands can wrap around parts of the baby's body, like limbs or fingers, and constrict them, causing serious damage.
Wow. Those complications, Potter sequence, pulmonary hypoplasia, compression, infection risk, amniotic bands, they really underscore just how vital that amniotic fluid environment is for normal, safe fetal development. That link between lack of fluid and underdeveloped lungs feels like a major takeaway on the potential severity.
They are definitely among the most serious potential outcomes that can arise from prolonged severe oligohydramnios, highlighting why diagnosis and appropriate management are so important.
Wow. Okay, we have really covered this topic from, well, pretty much every angle, based on these notes anyway. We've defined oligohydramnios, hit those key diagnostic numbers, explored all the potential causes and risk factors, understood the pathophysiology, the how it affects the baby, looked at the clinical signs, detailed the investigations, considered differentials, walked through the management approaches based on timing and severity, and discussed the prognosis and those serious complications. That feels like a really comprehensive, high-yield deep dive.
Yeah, I think it pulls together all the absolutely essential points from the material we were given, hopefully designed to be exactly what you need for effective revision.
Absolutely. And maybe as you, the listener, review your own notes and kind of consolidate what we've talked about, take a moment to ponder this thought. Really consider the different implications and the vastly different management pathways required when oligohydramnios is found early, say in the second trimester, compared to when it crops up as an isolated finding late in the third trimester or even post-term.
Right.
What does that difference in timing really tell us about the likely underlying causes, and how does it fundamentally change the challenge of managing what, on the surface, looks like the same condition, low fluid, but actually carries vastly different potential outcomes?
That distinction, timing often pointing towards cause, which then dictates prognosis, is probably the most critical concept to really grasp from this whole discussion.
I think you're right. So there you have it. You've just received a focused, high-yield summary of oligohydramnios extracted directly from expert revision materials. Hopefully you can use this deep dive to really reinforce your understanding and connect the dots in your own study.
And if you are looking for more high-yield revision resources, like the notes we base this on, the sources did mention checking out pastthemsra.com and freemsra.com.
Perfect. So explore those resources if you need more material for your studies. Thanks so much for joining us for this focused deep dive into oligohydramnios. We genuinely hope this helps solidify this important topic for you.
Yeah, knowledge is definitely your best tool, especially when you're preparing. Keep learning, keep making those connections.
We'll be back next time to dive deep into something new. Until then, keep exploring.